Hello everyone, I'm Pritesh Mistry, Policy Fellow at the King's Fund. I'll be your chair for this webinar today. Before we begin, I'd like to thank our sponsor, Capita, for supporting this webinar. So in this session today, we're looking at how to ensure virtual wards are a positive option for the future. And we've got a great panel of speakers today representing a cross-cutting range of perspectives. But before we introduce our speakers, I'll give you a little bit of a rundown on how the session is going to be playing out today. So this is a live event. Obviously, it's online. We're recording this event as well, so it can be watched on demand later for those who wish to catch up. We're going to be starting with a short panel discussion, then following with a live Q&A. So if you are watching live, please do submit your questions. It's through the Slido box on the right-hand side of the video. You'll also notice there'll be some poll questions that appear during the session. Again, please do take part. If you're on social media, we're using the hashtag KFOnline. And finally, we may be referring to some publications and additional reference material, which you can find on our resource page, which is on the left-hand side of the menu. So to start with, I'm going to go to each of our panelists to let them briefly introduce themselves. Firstly, handing over to you, Stephanie.
Morning, everyone. I'm Stephanie Somerville. I'm Programme Director for Virtual Wards at NHS England. So I have a small team that supports systems to develop virtual wards and some great clinicians on board in that team too.
Thanks, Stephanie. Dennis, would you like to introduce yourself? You're just on mute there, Dennis.
Sorry, please. Is that right?
Perfect, thank you.
Yeah, my name is Dennis Perkins. I'm from Leicestershire. I'm 75 years old. I was diagnosed with pneumonia at the beginning of June and went on to the virtual ward. So I'll be talking about my experience with that.
Thank you. Nikki.
Good afternoon, everyone. My name is Nikki Powell. I'm the Operations Director for Capita, and I support our health, education and welfare end users in regards to activity, which includes virtual wards, and look after virtual wards for Capita.
Thank you. Ross.
Hello, everybody. My name is Ross Fullerton. I lead all things digital data and technology across the integrated care system for Buckinghamshire, Oxfordshire and Berkshire West.
Thanks, Ross. Suzanne.
Hi, I'm Suzanne Armstrong, Advanced Nurse Practitioner in Arrhythmias, based at the University Hospitals of Leicester, and the clinical lead for the AF virtual ward.
Great, thank you. And thanks to all the panel. It's great to see you all here today. So we're going to move on to our first part of the session, which, as I mentioned, is a panel discussion. And to kick off with, I'd like to hand over to Stephanie to help give us an outline of the current landscape to help us get up to speed on what's happening with virtual wards.
Thanks very much. So I'm super delighted to be here with some fantastic speakers. And I think this debate's really important today because we're kind of at a critical juncture in the development of virtual wards. And it's really the development of a movement more than a programme. And I use the word movement because we're making a real and important shift with virtual wards from the idea that the hospital is the safest and best way to receive care, to delivering quality care in a place where patients may want it, and in the right place at the right time. So it's really exciting to be part of that. And the reason I chose movement as well is that this isn't something that can be delivered overnight or even within a year. You know, this is a major transformational change, and it's a complex change that needs to be championed by clinicians. So we get to the point in 5 years' time where virtual wards are a normal part of the treatment pathway for patients, and where residents know about their service and what to expect, and really embrace this as something they want to do rather than being admitted in hospitals. So we're there's a long journey ahead. Before I kind of talk about where we're up to now, just wanted to dwell on the definition of a virtual ward, because I know that we'll have loads of different people in the audience. So essentially, it's about providing hospital level care at home. And that might include care homes, so that as an alternative to admission in hospital. So that means that a patient might be referred to a virtual ward from a GP or an urgent community, an urgent crisis response service, or even by a paramedic. And that person will be assessed and admitted to a virtual ward, and that potentially will prevent a hospital stay. And then virtual wards also allow for early supported discharge from hospital, where patient might not need to be in a hospital bed, but does require clinical oversight and monitoring, and also treatment. But that treatment can be delivered at home. So that's what it's all about. And so I'll talk about virtual wards and hospital at home interchangeably. Our sort of definition of virtual wards includes hospital at home, where traditionally hospital at home has been a kind of face-to-face model at home, which hasn't historically been tech-enabled. But I'd sort of talk about the two things, and they are sort of one and the same. And of course, virtual wards sit in the ecosystem and virtual care. And I think there's a really important point, which we might get onto later, about the need to kind of leverage the investment that we put into digital platforms for virtual wards to encompass wider management of people on long-term conditions. That's an exciting sort of development for the future. But okay, where are we now? So actually, there's been a huge amount of progress that has been made, and actually we met 10,000 virtual ward beds last week, and we're now at 10,428 beds. So that's a doubling, a more than doubling of beds from sort of a year ago. And to put that in context, that's that's the kind of capacity of 20 hospitals, 20 small hospitals. So we're seeing a huge increase in the capacity of the NHS to be able to deliver acute level care. So that's fantastic, and we'll continue to see that number increase over the next 6 months as systems kind of fully implement their plans for virtual wards. And in terms of the kind of cohorts of patients that we're treating, every ICS has a frailty virtual ward, which is looking at treating patients with conditions associated with frailty, acute exacerbations of those conditions, and for patients with respiratory conditions. And we are systems actually to start there, because that's where we believe the biggest opportunity was. But systems are also expanding into heart failure pathways as well, and also looking at pediatric pathways. And very much we haven't been over prescriptive from NHS England to allow for innovation and to allow for systems to really sort of go where the energy is at this sort of early stage of the transformation program, but also to think about the needs of their local populations. So this is like a fantastic achievement, but it's kind of down to kind of the local pioneers on the ground, and really not much to do with what we do centrally. So the grit and determination to get there, because it's this is a big cultural shift for people as well, as recruiting the workforce, etc. Our challenge now is to really scale what we're doing to provide a consistency of an offer, but also to sort of embed virtual wards in the fabric of the NHS. And there's some really difficult things we need to sort of grapple with and develop solutions together. So I would say there's kind of 5 things that keep me awake at night when I think about it. Is funding. However, there's kind of positive news there in that the virtual ward funding will be part of a kind of wider UEC Urgent Emergency Care Fund over the next few years. That will, as the funding is there for virtual wards. So I often hear that as an issue, but we need to also really demonstrate positive outcomes at scale for the NHS, so that local systems can really be confident investing in virtual wards in the future. Winning the hearts and minds of clinicians is something I think we'll talk about today. It's not just a few pioneers now. We really need to make sure that staff really know what we're doing and are on board, and same goes for patients as well. There's a lot of mystery around virtual wards, so really want to demystify some of that for patients. And then we also just need to think a bit more radically about how we work. Can't carry on working in very siloed kind of acute trusts and community trusts, and how do we create more flexible teams for the future? And then finally, we've got a long way to go on tech. So it's our ambition for all all hospital at home virtual wards to be fully tech enabled. That means having a really great platform to be able to remotely manage patients, but it also means having rapid diagnostics so that people can rapidly be assessed and also treated at home. That's absolutely fundamental, and we've got a way to go there as well. So those are my 5 kind of things that I think about all the time, and I'm really excited to get into some of that stuff today. That's it. Thank you very much.
Thank you, Stephanie. That's really helpful, really good overview, and a good balance of where we are and some of the challenges for innovation in the future as well. So I think let's move on to hearing about how virtual wards are being used in the NHS and the experiences of patients and staff. So to start with, going to you, Ross, can you talk about the approach you're taking in Oxfordshire and Berkshire West ICS, please?
Yeah, thanks, Pritesh. And really interesting to hear that perspective as well about kind of nationally where we are, because in some ways I was reflecting we're a bit of a kind of small version of that national challenge across Buckinghamshire, Oxfordshire and Berkshire West. So we are 3 quite independent and strong places that make up our system, and they've all got different strengths and weaknesses. Some of our providers have been actively delivering hospital at home and virtual ward services for many years. And some of our providers are relatively new to this. So part of our approach across the system has been to understand the strengths that we've already got, to build on those, to understand the different pathways that are available, to help us think about where can we grow and scale our services safely and quickly, but also where are the gaps in capability and even the organisations that are perceived to be further ahead, or perhaps further ahead in some areas, but had some blind spots in others where there was opportunity to do perhaps the lower acuity patients, whilst they'd previously focused on the higher acuity patients, and we're doing that really, really well. You'll all have to excuse me, my voice is going ever so slightly today, so if I pause every now and then, bear with me. It took some time to get us in a place where there was agreement across the system. This is very much a kind of thousand flowers bloom kind of service that's very much led by clinicians who've had a real local passion in how to deliver these services, and that's a fabulous place to start. But it also means that everybody thought they knew how to deliver it best, and getting the trust and confidence across different partners in our system around how we deliver these services has taken some time, and it's been important to invest our energies in building that trust. We've also learned that the opportunities provided by the hospital at home and virtual care models start to cut across the traditional boundaries that we often see in the way the NHS is structured. A patient who would previously have been within the kind of physical walls of an acute hospital is now in their home or a care home. So they're then being attended to and supported directly by a different set of professionals than the hospital staff, who will still be involved, but there may also be care home staff involved, community workers, local authority carers, primary care, and the boundaries start to create some difficult questions to answer. How do we manage prescribing? How do we support the administration of acute level medication in the community? And how do we manage the complexities and challenges that throws up? Which IT system is the patient being managed through? The acute provider would probably prefer that they could see everything in their acute EPR because that's what they'll treat all their other patients through. But that's not necessarily the right kind of tool to be using in the community. So there are some complex barriers for us to work through that we've certainly not fully cracked yet, but are the kind of things that are important if we're genuinely going to embed and scale these services. We've got more work to do on getting that real single point of access to accelerate referrals into these services and amplify the scale. We know that the places that have got an effective single point of access see higher volumes of referrals in, and we are really focused on the throughput of our virtual wards to understand how effective they're being, as well as the number of virtual beds we have. And we've learned quite a lot around the acuity of our patients in our virtual wards can vary, and that can actually have a real-time impact on capacity, because we may be able to support 3 high acuity patients or 10 low acuity patients. And if you've got 3 high acuity ones based on the patient demand at that point in time, you might find it harder to onboard some other patient types. So having the single point of access that can understand that demand and capacity and support us to flex has been really, really key. And And then final point is then getting the confidence of the staff across the system to refer into a virtual ward. There's many years, 75 years of practice of seeing people in the NHS in a building, and suddenly they're not there. We've got to trust that at the end of this computer thing that is going to virtually support the information that they used to be able to touch and see and feel creates a really different environment. So helping with that education and training and support has been the final part of what we spent a good chunk of time on.
Thank you, Ross. Sounds like you're doing amazing work. And it's interesting to hear lots of questions popping into my head about how you support people to collaborate to continuously improve, and how you support people to work around the patient in a way that hasn't been possible previously, and how tech can potentially help that, but also hinder that as well. Moving on to you, Suzanne, if I can ask you to talk about your virtual ward initiatives, please. I think we'd be really interested to hear about the process of deciding about which candidates are, who's a candidate for virtual ward, and how you tailor support for those patients as well.
Yeah, thank you for this opportunity to talk about our AF virtual ward that we're running in Leicester. So we were one of the early adopters to the virtual ward model within Leicestershire, and we took the lead from our COVID virtual ward pathway, which had been successfully established. We've developed it into a different group of patients that sort of probably slightly different from the national model and national pathways. But we knew for several years that there was a real challenge in meeting the needs of patients with atrial fibrillation that were presenting in hospital, that were otherwise stable, didn't need to be in hospital apart from the fact that their heart rate was going so fast. So we had these patients that were sitting in hospital attached to a cardiac monitor on a bed for up to 5 days, didn't really need to be in hospital because they were otherwise stable. So we thought there was an opportunity there to take this care out into the community environment using a telemedicine approach. So we started off with an audit to start with, to actually see what the numbers were and actually how it would impact. And we saw that there was a year-on increase of 100 patients with atrial fibrillation that met this criteria. And when we looked at our admission numbers that came through from our clinical decisions unit, we saw that actually 50% of those patients that were being admitted probably did meet the criteria to be discharged with telemedicine as a supporting framework. To be able to deliver, like we already said, acute level care for these patients, because these patients have got a fairly high clinical acuity in that their heart rates were anything up to 140, 150. So we started with quite a tight clinical criteria in terms of who we were actually going to onboard to the virtual wards, making sure that the pathway was safe to start with. So we started off with small groups of patients, tested out the pathway, constantly seeking evaluation, sort of, thoughts and opinions from colleagues, but also importantly from the patients as we went through. And we did it via an electronic platform, which we chose along with the appropriate monitoring devices. So using a single lead ECG device so that we could review the patient's ECG on a twice daily basis as a minimum, with virtual ward rounds, with a small team of clinicians who were specialists in arrhythmia care. So myself and 2 other advanced clinical practitioners review the patients on a daily basis with other support from the wider multidisciplinary team, and obviously a specialist consultant oversight. So we started off very small and gradually grew the model, but we were quite clear from the outset what we wanted to deliver for patients was to actually improve the whole patient pathway. So these are patients with long-term health conditions who were coming into hospital sort of after they've had an admission, being reviewed 6 months down the line, and then having a medical management plan and whether they were going on and having procedures or medical treatment. So what we wanted to do was shorten that pathway, making sure that the patients were getting the right care at the right time by the right people, to reduce their healthcare contacts and also reduce then the impact on the wider healthcare community. And as part of that process, we've developed and grown. We're doing prescribing for these patients on an almost daily basis and just in the medication, but that's owned by the virtual ward team to reduce the impact on primary care again, but actually integrating our systems and working towards doing a pilot at the moment of prescribing for patients out in the community, which has its challenges, but hopefully being able to do electronic prescribing so that patients can collect their medication at the point closest to them, rather than coming back to the hospital to get that medication. So importantly, we're trying to get them to destination therapy sooner by disrupting that traditional clinical pathway, making sure that the individual needs of the patients are met. But importantly, because they have got a long-term health condition, making sure that we are empowering them to have the skills and the knowledge and expertise to manage their own condition, so that further on down the line, they're not having to come into hospital to manage these acute episodes.
Great, thank you. Really struck by the aspirations that are driving you forward and the practical steps and being able to grow confidence and workflows and processes and the way people work together. That's fantastic. Thank you so much. And now I think it'd be great to move on to Dennis. If you could share your experience of this approach to healthcare, please, Dennis.
Yes, you can hear me okay, can you? I'll push the right button.
Yes, that's great. Thank you.
Right.
Yes, well, I was diagnosed with pneumonia on the 16th of June. It was slightly complicated by the fact that I'd been diagnosed with diabetes type 2, but with very high readings the week before. The two weren't connected, apparently. It was just bad luck. But I went to Glenfield with the pneumonia and spent the day there going through triage and being assessed, having all kinds of tests and so on. Had fantastic treatment and to be honest, really was impressed from day one with the standard of care and the quality of the personnel that I was dealing with. It was lovely. Then, of course, they introduced me to the concept of the virtual ward, so that I would be a good candidate to be registered with the virtual ward and be able to go home, which was immediately a positive effect on me, because I thought, yeah, this is great. You know, it reduces the stress of being in hospital and trying to think of all the things you've got to make sure you've got with you and what you need, especially if you've got other conditions, like at that time, the diabetes I was just trying to get come to terms with. So to be able to go home and recover and still be monitored so closely was really a good idea, I thought. And they sent me home with a little briefcase full of kit. And we had a run through, you know, with how to take your temperature, how to take your blood pressure and what figures and so on. And then there was a small tablet, a small computer that they gave me to put the figures in every day, and that contacted directly the pneumonia clinic. And what happened every day was that I would take the readings and then send them in via this tablet. And without fail, within 20 minutes, half an hour, I would get a call back from one of the nurses at the pneumonia clinic. They would ask me a number of questions about how I was getting on and so on, and report back to me what they thought about the readings. And this gave me a lot of confidence. This was happening twice a day. And in the meantime, I was able to just relax, watch what I wanted on the television, eat what I wanted, subject to the diabetes, and get a little bit of exercise. But I must admit, I was pretty ill the first couple of weeks. I couldn't do very much physically at all. But there are a lot of advantages from the patient's point of view. I'm sure a lot of people would understand that, you know, if you're at home in your own surroundings and you can do what you like every day within the limitations of your condition, it's better than being in hospital. And of course, for your family, they haven't got the stress of having to try and visit you. It lowers one's carbon footprint a little bit as well, doesn't it, when people are not backwards and forwards to hospital all the time. But I couldn't have been more impressed with the way that I was looked after, and I was never ever felt that I was being isolated from the unit. It was almost as though I was still in there, and that was down to the staff. I think they're wonderful in there. And I gradually got better over a period of time, and just had one little blip when I was taking paracetamol because my temperature wouldn't come down, but we then discovered I wasn't using the thermometer properly, pushing the wrong buttons, and I got suspicious when the reading was high but always the same. And I used an old-fashioned thermometer that we had in the cupboard and discovered that my temperature was actually normal. So once we sorted that out, things went smoothly. It didn't interfere with the medication and so on. I had the antibiotics and everything. And then everything that they said would happen, happened. That's what I liked about the unit there. They kept me informed about how I was doing and what I should expect. So it worked extremely well. And I don't know whether that's covered it pretty well for you. I think it's
Thank you, Dennis.
I'm well enough to start playing football again 3 weeks ago. So everything they've done for me has worked. Oh, and I went 10-pin bowling yesterday with my grandson and he beat me. So but
Thank
yes,
you, Dennis.
it's been a good experience, and I would say that I could not really think of anything that that was wrong with it.
Great. Thank you for sharing your personal story. I think it's very important to have the lived experience in these kind of conversations as well. And now, lastly, Nikki, if you'd like to share with us what you're seeing from your experience. How do we deliver these at scale? How do we ensure people are supported in a virtual ward setting? So we make sure that the best services are available.
Yeah, thanks, Pritesh. And I almost feel guilty coming after Dennis now, after hearing all of that great news. It's lovely. Yeah, and actually, for me, that's really, really good. Listening to a patient's journey around how they feel that they were supported at all times, that they didn't feel that they were getting a different level of service compared to when they were in a unit or in a ward is absolutely critical. So our aim has been to support the NHS to enhance the virtual ward or the hospital at home offering. But we have the knowledge and the expertise of being able to deliver that at scale for large scale requirements and look at it from an outside-in perspective and doing just that. So we like to meet the NHS where it is today. I think Ross came across really, really well earlier on in saying they're all in different places, etc. And everyone is taking a slightly different slant or different approach, and it's easier for us to take all of that in and absorb all of that and take the great work that has already been done and incorporate that into a model that combines the knowledge and alongside our ability to scale at pace where it's needed, but in a controlled, pragmatic process that puts the likes of Dennis as a patient and our clinicians at the heart of everything that we do. What that will do is it enables us to deliver a single hub of an ecosystem. That means that it doesn't matter whether the patient's in John O'Groats, Land's End, wherever that might be, they get the same level of quality care that Dennis is calling out as what made him feel like he was almost the only patient that is being dealt with on a day-to-day basis. So it's about giving that personalised care in a scalable environment. So our aim is to enable the NHS and the ICS and even local government from tech-enabled care, etc., to scale that sustainable model, which means that it puts the clinicians at the heart of being able to focus on what they do best in spending time in a clinician activity. And we can support them with the non-clinical elements to offer that time that's often time absorbing, to take that away from them so they can focus on that end-to-end journey for people like Dennis and as importantly Dennis's carers and family members and people like that want to feel that they've got that all-inclusive environment that supports them just as much as the patient at hand. That's the aim of everything that we're doing with this hospital at home approach or virtual ward, whichever way you want to call it.
Thank you, Nikki. That's very inspiring. That's great. Thank you so much. We've got a lot of questions coming in. There's one more thing I'd like to cover before we go on to the questions. Maybe I can combine the first question we've got with the next thing I'd just like to touch on, which is around confidence, the confidence to use virtual care. So I think building confidence is really key to enabling effective use of these virtual approaches to care. And that means staff, patients and carers are confident in the technology and the approach. So it'd be good to hear from your perspective and the work that you've been doing, what's needed to build the confidence to get the best care with virtual wards and the acceptance with virtual wards. So if I could start with you, Dennis, I think particularly I'd be interested in what helped build your confidence, but also how you'd like to see yourself in future, as well as other patients and the public being involved in these kind of initiatives.
Yeah, I really think that the question of confidence is down to some extent to your own circumstances and whether you're adaptable enough and fit enough to be able to look after yourself sufficiently, or if you've got family around you, as I have, and they are supportive. But the contact with the unit is the thing that gives you the high confidence, I believe. When you're sent home, you don't feel isolated, you don't feel on your own, you don't feel you're fighting your own battle. They're still calling me, these nurses. I had a call last Sunday afternoon, believe it or not, from Manera in the pneumonia clinic to see how I was going on. And of course, I'm still having x-rays every 6 weeks because there's still a slight shadow there. And she wanted to discuss that with me. And she said, it's getting better each time, so we're going to make you another appointment. But the care, it just, it is overwhelming to some extent. It's lovely. And you hear so many bad things about the NHS. But when your experiences are good, like mine have been, then it fills you with confidence anyway.
Great, thank you, Dennis. So I think there's something coming out around communication, reliability, that's really coming out to me there. So if we could go on to you, Ross, be great to hear a bit what you're doing to build confidence in the staff and the teams.
Yeah, thanks, Pritesh. And I think if I take two sides of that, so with our staff, it's about education primarily and supporting them to understand this new model of care that if they've not been directly involved with, it might just all seem a little bit odd and strange. So the bit of taking the time to help explain and understand, and it's difficult to find that time in the pressurized world that we're all working in today. And then we're trying to standardize. Now we've kind of come through that kind of last year or so of kind of really growing the services to get things like consistent SOPs, operating procedures across the different organizations. We've got 3 acute trusts, 2 community and mental health trusts, various other providers involved in delivering our virtual care services. So trying to get that consistency and standardization is really helping. Things like acceptance criteria, when would it be appropriate for a patient to be admitted onto a virtual ward? The more we standardize that, share learning for any potential incidents or safety concerns that might have ever emerged, so that people can see that we're really closely managing and watching that to again build that confidence. And then building it into the standard practice, so where we talk about what's the capacity today in a particular organization, we're not just talking about the physical beds, we're actually talking about the virtual beds in that same space, so that we can make it part of everyday working and not this kind of new thing on the side that people don't understand. So that's really helping with the staff and professional colleagues. With the patients in our populations, we spend quite a lot of time engaging, understanding how they feel about these services, what they might be concerned around. And then using storytelling, very much as Dennis has just shared his lived experience with us today, capturing stories from patients, from their families and carers. Things like our palliative care pathways had a really incredible impact, and hearing from families of those patients who had a much better end-of-life experience through being able to be on a virtual care pathway are really compelling in terms of sharing that and building the confidence both with the general population and our clinical colleagues. And we've moved away on accepting Stephanie's kind of language around the technical differences of a virtual ward versus hospital at home. Our population doesn't understand what a virtual ward is. So across our system, we outwardly call it a hospital at home model because our patients can relate with that much more readily. So there's a range of things going on. There's a lot more to do, and we need to keep on learning from each other as we go through this.
Thank you so much, Ross. If I could move on to you, Suzanne. So building confidence, but also public involvement or patient involvement as well.
Yeah, it's really important to make sure that you keep everybody in the loop in terms of this new landscape of care that we're providing at the moment. And we've worked really hard to work with, particularly at the times when the doctors change on our admissions unit, and we have to go back and almost start again to educate them and support them in terms of what services are out there and how we're supporting these patients, so that they start to build their confidence in the service that we're providing. As a specialist team, you know, we feel comfortable managing these patients, but it has been a challenge from our point of view as well, as learning to manage these patients in a different care environment. So, you know, it's important to make sure that everybody's kept in the loop, and also to regularly audit and evaluate what we're doing, and actually be able to share that audit data to show that the pathway is safe, what our readmission rates are, you know, how long the patients are staying on the virtual ward, and the discharges that we're doing. And in some ways, actually, the fact that when there are patients that need to be readmitted because their condition changes and they become more acutely unwell, demonstrating that the pathway is safe, that these patients are being picked up and managed appropriately and then readmitted through the appropriate channels is also demonstrating the safety of the pathway, but also making people more aware of the care that you're actually providing for these patients. It was a challenge initially to talk to patients about going onto the virtual ward as well, because, as I say, it's a very new landscape of care for patients and their families, and they needed to build their confidence in what we were providing for them. So we spend quite a bit of time explaining to the patients what the service is, but importantly going through the support mechanisms, how they can contact us and what to do if scenarios. So out of hours, you know, in the evening, they've got a number to call, somebody to ask some advice if they don't need to be readmitted, but obviously reinforcing that the emergency numbers as well, because of their level of clinical acuity. So that's important to build that confidence. But what we found is, from doing our patient evaluation day and feedback forms, that actually after the first 24 hours, people felt much more comfortable being at home. They was surrounded by their family and friends, and they were able to some degree be able to get back into their normal routines, but knowing that we were quite responsive to messages via their electronic platform or telephone calls, that there was somebody at the end of the phone looking after them, supporting them, to guide their care. What particularly is important is that you spend the time initially talking to those patients about what their care needs are and how you're going to contact them. So one model doesn't fit all. You can't do everybody through an electronic platform. There's a certain amount of information comes through the platform, but some of the patients, perhaps some of the more elderly patients, were keen to have that daily phone call from us, just to touch base, so that they knew we were at the end of the phone. And it was making sure that we put that in and found out what support they wanted in the first instance. That was quite important in developing that confidence, but, you know, that two-way relationship, that rapport with the patients.
Thank you so much. Some parallels coming through between you and Ross, with the need to audit and evaluate, continuously learn and improve. And I'm so glad you mentioned that one size doesn't fit all, because I think, you know, it's having that flexibility as well within the system. Nikki, if I could bring you into this as well.
Yeah, I wholeheartedly agree with both what Suzanne and Ross have said. I think one of the key areas that we've been focusing on is exactly that the one size doesn't fit all for all of our patients and what they require. So it's about making sure that you have alternate options, that whether that's for somebody who isn't digitally focused or doesn't use digital in any way, that perhaps might need a phone call on a daily basis because they live at home on their own and don't get any interaction. So there's lots of different pathways that can happen to make sure that it's still a tailored level of care that they would normally get in a hospital setting whilst they're at home, that suits both what they need from a clinical setting, but also at the same time suits the fact that they're in a home and they might have different things going on. So I wholeheartedly agree that I think there's been different ways from different tech that are available, and making sure that that tech enables the right level of care at the right times is exactly what we need, and is what we've been focused on. And I think the biggest part of the activity that we've been doing is around our patient panel and our patient pathway, that includes the relatives and the carers, to make sure that it isn't it isn't just what we need from an NHS perspective, it's what we need from a patient's perspective also. So our big challenge has been around how we match those things together to give that a level of ability to scale safely in the right setting, but also with the right tech that enables that, whether that's a traditional landline versus using a mobile phone versus using an iPad, and everything that goes in between. So yeah, I only echo exactly what both Suzanne and Ross have said today.
Thank you so much, Nikki. It's amazing that we can still talk about the telephone today. And moving on to Steph, if you'd like to just add anything extra on public involvement and building confidence, please.
Yeah, I mean, sort of the design of virtual wards has to, happens locally, and there's some fantastic pieces of co-design work happening across the system. But there's something I just wanted to touch on, and we just did a really great piece of behavioural insights work to really dig into what increases confidence and sort of why people are worried about referring. And one of the really interesting things that came up was that, part of this is a kind of changing habits, and habits are those really strong drivers, unconscious drivers of day-to-day behavior. And so there's some practical things we can do to sort of change those habits. So for example, where people clinicians are unsure about referring into virtual wards, we found that if they'd actually had a really good referral experience, then they were, that sort of started to break the habit. So there were some things that that we found that were really effective, like ensuring that all sort of inducted clinicians have like an end-to-end walkthrough of a virtual ward. Also, that their first referral was really fantastic, and that communication worked very well. They knew who the clinicians were, etc. And that first experience was really important. And I think it's just something touching on what Ross was saying, that a lot of our language around this is about the hospital and wards, and actually and also about transformation, which I've used, so I apologize for that, but we need to attempt to normalize the pathway as well, and sort of get away from the idea of the security of a bed and talk about sort of broader care. So there's a kind of normalizing of the comms, and everything we do is really important, but it's not just about obviously telling people what to do. It's about understanding that we need to kind of fundamentally sort of shift behavior.
Thank you so much. Amazing. So we're going to move on to the questions that have been submitted to the audience, and I think I'd come to you first, Stephanie. Has there impact on informal carers of patients on virtual wards been assessed, or have there been any assessment and consultation with carer groups? And after Stephanie, it'd be good, Dennis, if you've got anything you'd like to add from your personal experience.
Yeah, we are work at a sort of national level. We do work with carer groups, because obviously this is sort of the pressure on carers is something that an issue that we're very alive to, and that doesn't just happen nationally, but sort of carer groups are involved in the sort of design and development of virtual wards locally. And what I would say is that going on to virtual ward is a choice. It's not something that patients have to do, and it's very dependent on whether they've got the right support at home, and a clinician must and do take that into account when making an admitting decision, and that's so important. So I guess yes, we've done a lot of work with carers. We don't have a formal assessment. We haven't got a sort of national evaluation assessment of that will come, but carers are very much involved in design, and also I would say that the virtual decision to make an admittance to a virtual ward should never be something that's forced on people. It depends on circumstances at home.
Thank you so much, Stephanie. Dennis, you mentioned being in your own home and having the people around you. Is there anything you'd like to add to that?
Well, yeah, I think what was important for me, it just happened this way. My son and my wife both came with me to the hospital when I was first admitted. And of course, I'm sure a lot of patients would say this, they go through triage, they see a lot of people, they have lots of tests, they get a lot of feedback, and you don't take it all in, do you? And if you've people with you, your family, they are listening as well. And
that is a tremendous help. You know, I think the nursing staff and the doctors at the at Glenfield Hospital are probably aware of that. So if someone's there and they're stressed and they're not able to take it all in, I'm sure they make allowances for that when they're trying to make sure that that person leaves with all the information they need. But I myself did benefit tremendously from having my wife and my son taking a lot of notice of what was being said, even making notes and so on. And they were reminding me when we got home of what I'd got to do. And yeah, I know it sounds strange, but it's what happens, doesn't it, when you are ill? I mean, it's difficult for me to sit here now and really think about how ill I was and how bad I felt. But if I tell you, I could hardly walk up the garden, you know, and your mind is all over the place, isn't it? So I think the confidence thing is very important. There are many ways you can achieve that. Very important point that's been made again is that keep the contact with the patient so that they can rely on the fact that they can, and I did call the unit once or twice with questions and they answered, and if they couldn't answer straight away, they would get back to me. They did what they said they would do. You just got to trust them. And trust is the big word, isn't it, when it comes to confidence. If you trust in everyone, you get good confidence levels.
Great, thank you, Dennis. Anyone else like to come in on the work with carers and engaging with carers? Otherwise, we'll move on to the next question. Oh, great. So maybe Ross and Suzanne, we've got a question around children and young people's virtual wards. I'd be interested in hearing from you on how that is, how you're thinking about that, if you're doing any particular work in that particular area. It's the questions focusing on, well, it says that there's a focus on adult wards and potentially children and young people wards are falling by the wayside. So it'd be great to hear from you too on that.
Yeah, I'm happy to come in first, Pritesh. I think it's a really interesting area. So we have got one paediatric virtual ward. It's very small in its scale, and it's the area we'd like to do more on. I think really simply, if I understand it correctly, the national funding was targeted towards adults, and we therefore focused on that as the bit that we were being measured against, because the incentive leads to the outcome. So if we could look at that incentive model to broaden the scope and opportunity, and I think there is work coming in that space, then that allows us to broaden out into that important area. There is, I think as well, there's been a bit of kind of learning as to how do you better support people through some of the maternity processes as well, and there's the maternity virtual care opportunities. So even going to that all the way through that start well journey, as well as the getting into live well, how can we support that too? So limited experience, but I think we need to do more.
Great, thank you, Ross. Suzanne, anything you'd like to add to that?
I personally don't have much to add, but I think it's a great opportunity to look at children and developing these services going forward, because, you know, children, particularly from a technical aspect, are very savvy that way and are used to using that sort of media for more so than probably some of our older adults, although we've seen a massive change in that since COVID. So I think, you know, it's definitely an area for growth for virtual wards.
Thank you. And Stephanie, is there anything you'd like to add to that as well?
Yeah, I mean, we've got some guidance coming out, I think, or often have guidance coming out that describes some best practice in managing patients on paediatric virtual wards. I think there's real potential for managing, and maybe it's more in the virtual care space as well. So managing children with really complex needs when they have to go to appointments all over the place, and sort of bringing that care closer to home. I think there's real benefit there. So yeah, I guess watch this space.
Thank you so much. And while I've still got you, you mentioned hospital level care. There's a question around what's the definition of hospital level care. Maybe we'll get into a constant ask of definitions, but the I suppose the clarification is that there's lots of modern community services already provide urgent care at home.
Yes, I think it's about the acuity of patients treated, and there's no, hard. It can be a bit of a grey area, and I know that community services have been, for example, giving, treating patients for lots of different complex needs, but there is a difference between acuity here, and a virtual ward is we're trying to really replace that spell in hospital. So it's a time-limited intervention when someone is really quite unwell, and getting them back on their feet. And that might result in an admission back into hospital if their care doesn't stabilize. But that's, I think, what sets it apart from sort of other community services. But the line is never completely clear, and it really depends on how local services are set up as well.
Great, thank you. We've got a question around digital exclusion, so I'd like to bring you in now, Nikki, if that's okay. So kind of how have you seen providers giving consideration to digital exclusion and the patient's ability to connect? So especially considering that you don't want to add more risks of exclusion, more stress upon the patient. Yeah, it'd be great to hear from your experience on that.
Yeah, I think it's been a real focus, certainly of ours, of making sure that we have the right setup to start off with, and being really clear for onboarding of patients into a virtual ward setting is to whether it is appropriate and can be supported in a home setting for the patient. And if that's, if some of this communication is actually just can be as easy as a phone call to check symptoms-based surveys, etc., that are really easy to do. And actually that means that the digital enabled is actually quite rudimentary in what it is, as long as they've got a bit of availability of a telephone. And then it can get much more complicated dependent on the level of requirement from a patient. But it all becomes part of that pathway of onboarding a patient into that and making sure it's the most appropriate thing for the patient to do in the first place, and having multiple options that are available to deliver, which is why working with clinicians around how we onboard patients at the right time using the right methods is absolutely critical, and it's been a real key focus of how we do that from an onboarding perspective of what is required for symptoms-based management, what is required in regards to general patient care, and making sure from an empathy perspective, how are we dealing with that, and how can we match those together that means that we're getting the right results for everybody, clinician, patient, and the NHS from a beds requirement perspective. So it's about having there is never a one size fits all. It's about making sure that you have multiple pathways that you can almost do a pick and mix to make the most appropriate care for that particular patient at that time. And that might change, if symptoms get worse, etc., you might have to add or take away as they get better on that basis. So it's making sure that you can adjust that care and that pathway as the situation changes over that period of time.
Great, thank you, Nikki. And maybe if I can bring in Dennis, it'd be great to hear a little bit about your experience of I suppose, how you use technology generally and how you've experienced it as part of virtual wards. And then Suzanne, you also mentioned one size doesn't fit all, so great to bring you in after that. Dennis.
Yes, I wouldn't call myself computer literate. I get along with it. I only learn enough to be able to do what I have to do. And I think when you get to our age, you feel your head's getting rather full of new technology and stuff, and you've got to push something out of one end to get something new in the other. It can be a little bit overwhelming. But when it comes to using the equipment and the mini computer and so on, it was okay. I'm used to using a desktop, and I'm used to using a smartphone for doing quite a few things. But yeah, I mean, if are you asking me how well educated you have to be in digital technology to be a virtual patient?
In a way, I'm just trying to gauge, I suppose, how you found that onboarding experience. And if you as you kind of mentioned, you're not a tech expert, and it sounds like you found it quite an easy experience to be able to use that tech.
yeah, what I had to do was to use this tablet every day, and that was very straightforward once I'd been shown. So that wasn't a problem really.
Great, thank you, Dennis. Suzanne.
Okay.
Yeah, I think it's a really important point is making sure that that is accessible to all patients, and that we are making sure that we're not being digitally exclusive, but we're being more inclusive. And that's one thing that we particularly worked hard on with our pathway. So we had equipment, like Dennis said, he was given a tablet. You know, we can loan out iPads to patients if they can't download the app on their smartphone. But one of the things, particularly when we looked at the digital platform that we used, we spent quite a lot of time making sure that the patient-facing app was as straightforward, very simplistic and easy to use, and very easy to navigate, because at the end of the day, clinicians can work their way around their own platform and how we can manage the patients, but it's actually the patient-facing thing that's actually going to be the success of the project. So that was really important. The other things we looked at was the social support that was around the patients and their families and their carers, and sometimes we had relatives popping in to help them do their measurements and transmit the data through if needed. Often it just took the first 24, 48 hours for people to get familiar with using the equipment and submitting the readings, and then they were able to be a bit more independent with it. But, you know, we really stressed the importance that it wasn't not to be a stressful thing. You know, we're at the end of the phone, we can talk you through how to do it. And we have done that on multiple occasions. So it's making sure that people know that don't stress it. There's ways around that we can get this data from you, this information. It's important that you are comfortable with it. And as we've said at the beginning, is that you don't have to have virtual ward care. That is just another option of delivering it. We had 2 patients that declined it because they just thought that was early on, that it was going to just be too stressful. But the majority of the patients, we've been able to sort through the process. We've managed to support people up to the age of 96. And we've also had visually impaired patients use the platform and the kit as well with no difficulties. They've got their own adapted iPads that could speak to them, and, you know, we were able to manage that process.
Thank you, Suzanne. It speaks very strongly to patient choice, I think, having multiple options, and I don't think that is unique to virtual wards. So we published some research in March that showed very similar aspects of make care more inclusive. So we're rapidly running out of time, but I'd like to touch on one last question. Maybe Ross, Steph and Nikki, if there's anything you'd like to come in on this question on. So how do virtual wards interact with the charity sector, or how are you kind of working with the charity sector to try and bring them into some of this virtual approaches to delivery of care? Ross, if you'd like to come in on that.
Yeah, thanks. So each of our providers, particularly our community providers and our some of our things like our GP federations, who provide a lot of the community care service side of this. So our virtual care model is, yes, it's kind of acute level services, but actually often delivered with the genuine partnership across the system. And they've got good relationships already with the relevant local voluntary sector organisations specific to where they work. So they're really building on that local relationships already, working with those that are on the ground, able to support that delivery. And it can be things like supporting those who we've just been talking about. Do you have someone able to come in and support you with those first few days? We've got some great relationships with organisations helping in that regard, for example. But it's an untapped opportunity. We've got a lot more to do. We've done some quite large events around virtual wards with partners across the system that we're increasingly getting interest in a voluntary sector to join and help understand. They want to understand where they can help as well. So yeah, lots more to do again.
Great, thank you, Ross. Stephanie and then Nikki.
Just unmuted. Yeah, I don't really have much more to add. I think there's a huge untapped opportunity, as Ross said here. to use the great expertise and reach a voluntary sector have, and it has to be a sort of local relationship developed. We are thinking about working with the Red Cross and some others about thinking what we could do on a sort of more systematic basis to support virtual wards. It's kind of early days yet, but yeah, I just would reinforce everything Ross said about how we could really, it's a support for carers as well that was talked about before. How can we support patients and carers in this space?
Thank you. Nikki, anything you'd like to add to that?
Yes, I suppose certainly from our perspective, and I talked a little bit earlier on about the ecosystems that we're trying to build, especially in our local government teams around it. This isn't a one size fits all. That, you know, certainly from a carer's perspective, they don't just look at it from one of their patients being poorly, etc. It's around their overall continuous care as we go through. So we support our local networks to facilitate and help scale that in those local areas, but without building on top and adding more and more layers. We do a lot of citizen training and communication, and it's about understanding how the tech-enabled care that we potentially will need to move into, certainly from a frailty perspective, how does that link together? And work with some of our out-of-hours teams that we also have at the moment to make sure that it's not just a 9-to-5 provision, and that our carers generally actually probably need it at the back end of each day, etc., as things becoming more challenging. So we work as part of that local government network to be able to support in ways of doing that isn't just for the NHS, but will support the NHS in its overall delivery from that perspective. So but there's still lots to be done, as we always say. There's lots to be done all of the time. So it's one of those things.
Great, thank you so much. I think, you know, it's really speaking to me about how much impact it's had already, but yet how much further we could possibly go. So thank you to Dennis, Suzanne, Nikki, Ross, and Stephanie, and thanks to Capita, our event sponsor. This recording is going to be available until the 30th of October, so please do watch back or share a link with colleagues who can register and watch on demand. And we would really appreciate it if you could use the feedback option on the menu on the left so we can continue to improve our events. Thank you once again for the audience and our panelists. Hope you return again for a future event. Thank you.